Good evening and welcome to a special guest webinar by Physicians Association for Nutrition Israel. We are a part of an international organization of professionals, dietitians, physicians, and other professionals, health professionals, aiming to reduce diet-related diseases, improve lives, and rethink health. One of the ways we choose to do that is by joining hands and getting updated in evidence-based knowledge on how to prevent and treat diseases by healthy lifestyle and especially healthy nutrition. So I'm very excited and honored to host Dr. Rani Polak, who will give a lecture on culinary medicine. Rani is a senior physician at Sheba Medical Center, the founding director of the Culinary Healthcare Education Fundamentals Coaching Program, and also a course director of a medical education program at Harvard Medical School that disseminates culinary coaching to hundreds of clinicians worldwide. And lastly, I would like to mention that I'm proud to have two scientific articles we published together about a program for professionals that had the element of a culinary medicine alongside healthy nutrition and physical activity. Thank you for that also, Rani. And we will have a Q&A session at the end of the presentation. So leave the questions to the end. Rani, the screen is yours.
Thank you, Rani. Yeah, we worked together, I think, more than a decade ago.
Yeah, 15 years ago.
And it was great to meet you again this year with a colleague of mine, which is also a colleague of yours, and it's lots of fun. Okay, so let's start. I think this slide is kind of waste of the time of the audience. I'm kind of preaching to the choir. So I think you're all here because you understand the importance of nutrition. So we will cover today the topic of culinary medicine, and I will start with the case to address home cooking. Why this is so important to address home cooking, and then we will move to understand the health consequences of consuming ultra-processed food, and why this is such a hot topic today, although we are consuming ultra-processed food for decades. And then we will talk about the emergent fields of culinary medicine, and how we can use culinary education as a strategy to improve nutrition. And I will finish with a few tips about cooking legumes and what I do when I'm not teaching here. So let's start with the case to address home cooking. So most of the data that we have is from the US. So I'm presenting primarily data from the US, and maybe we'll have in someday only data from Israel about home cooking, and maybe there is, and I'm not aware of. But this is the how much people make food at home. And you can see the differences between 1965 and 2007 and 8, and actually there is a decrease in 23% in the past 40 years in the amount of food that people prepare at home. On the other side, you can see that there is a huge increase in eating away from home, and you can see that the decrease is 23% and the increase is 42%. It's not the same, but the first study measure energy, the second study measure dollars, so it's not really the same. But you can get, you can have the main, the main changes here, that people are cooking less and less at home and consuming more and more food outside and more ultra processed food. So you can ask, and the next question could be, why this is so important? I mean, why this is so important if we cook at home or not? And there are quite interesting studies in this area, and this one is a study that evaluates one small piece of the Enhance. Enhance is a national survey in the US, quite similar to Mabat in Israel, like different questions, but it's like national survey that they disseminate once every few years. And one of the questions was, how many home cooked dinners do you consume per week? And it's like the first line here. And you can see that they divided the responders into three groups: those who consume 0 to 1 home cooked dinners per week, 2 to 5, and 6 to 7, and they match it with the calorie consumption. And you can see that although they didn't measure healthy cooking, they didn't measure healthy cooking ingredients, just how many home cooked dinners do you consume? And you can see that like, for me, it was surprisingly, I'm not sure how it's about for you, but you can see that as much as people consume more home cooked food, they actually consume less calories. And and if you wear your clinician hat, so it's kind of interesting because people do lots of compromising to consume healthy food and to reduce calories, and you can maybe eat almost all what you want and just cook it at home, and you can cut on your calories. And I think that the second line is even more interesting because there was another question that asked if you're trying to lose weight. And they did a sub-analysis only of the people that answer no to this question. Actually, we eat maybe what we want. We don't care what we eat so much. We don't care about our calorie consumption so much. And you can see that even within this subgroup, as much as people consume more home-cooked food, they consume less calories. Moving on to data from the UK, it wasn't a national survey, but it was a huge cohort that measured more or less the same question: how many home-cooked food do you consume per week? And they divided the responders slightly different. Less than 3 to 5, and more than 5. And they didn't measure calorie, they measured all kinds of food groups. And you can see, again, they didn't measure healthy cooking, they didn't measure cooking healthy ingredients, just how much home-cooked food do you consume. And you can see that as much as people consume more home-cooked food, they actually consume more fruits, they consume more vegetables. And even if you looked at the overall dietary score, you can see that their diet is more aligned with the Dutch diet and more aligned with the Mediterranean diet score. And again, I think this is very, very interesting from the behavioral perspective, because we are putting so much effort. Those the clinicians that do talk about food with a patient. I know that not everybody talk about food with a patient, but if you talk about food with your patient, you probably putting lots of effort to help your patients to do many changes, such as consuming more vegetables, such as, reducing, saturated fat, eating more fibers. Here, with only one behavior, home cooking, you can help your patients to accomplish lots of nutritional goals. So moving on to health and diseases, and you're probably aware of the North Health study and the health professional follow-up study, like two of the major, if not the major studies that were done in the past decade, and a small component of this cohort is asking the participants how much and how many home cooked food they consume. Here they was more sophisticated because they included lunches, so it's like lunches and dinners. So it's meal prepared at home. So here the total is 14 and not 7. And you can see that those who consumed 11 to 14 meals prepared at home per week actually had lower risk of developing type 2 diabetes than those who consumed 0 to 6. So it's not only healthier food groups, it's actually reducing the risk to have chronic disease. And this is most probably because of less weight gain. So, the question is why? Why consuming home cooked food is important. And I know that, in home cooked food could be compared to eating away from home. Home cooked food could be compared to eating ultra processed food. You can eat ultra processed food at home as well. So so the definitions here are not so accurate yet. We are working on this, but I think it's important to understand that today we have better data that present the health consequences of consuming ultra processed food. And the reason that there are many papers on this topic in the past 2-3 years is a new food classification, which we call the Nova Food Classification, which is, to my opinion, like really innovative, because this classification looked at food in a totally different way than we used to look at food. Because like the traditional way, scientists and clinicians look at food is according to food groups. There are healthy food groups and there are unhealthy food groups. And here we looked at food from a different perspective, and to what extent the food is processed. And just as an example, group 1 is unprocessed food or minimally processed food. And you can see that in the same group, you can find vegetables and beef. It doesn't make sense in so many other food classifications. But here they only looked at the level of to what degree the food is processed. So group number 1 is minimally processed or not processed at all. And here you have a few examples. Group number 2 is processed culinary ingredients. This is quite a minor group, and those are modified version of group number 1, all kind of processed food that you use for cooking, such as salt, olive oil, sugar, and ingredients like this. Group number 3 is processed food, and those are a combination of group 2 and 1. Mostly processed food that includes few, I don't know if to call it ingredients, because ingredients you call something when you cook, but 3 to 4, let's say, ingredients, such as cheese and bread and canned fish and all kind of syrup fruits. And class number 4 is ultra processed food. And here you include all kind of formulation that's made mostly or entirely from substance that's not usually included in food. And again, here you can find a really interesting combination, for example, of protein bars, which I think many of our patients will consider healthy food, together with burgers and meatballs and other ultra processed food. And another example is food that includes all kind of additives, such as preservatives, antioxidants, stabilizer, non-sugar sweeteners, all kind of items that include further processing of food, such as hydrogenated fat, soy protein isolate, and all the small letters that you can find on your package. So this is a really new classification, and in the past 5 years, we have high index papers that show what's the impact of consuming ultra processed food. And I can give you a few examples, and this is the first one, and it's ultra processed food and mortality. Straightforward from BMJ 2019. Higher consumption of ultra processed food is associated with 62% relative increase for all-cause mortality. Okay, this is strong. And for each additional serving of ultra processed food, all-cause mortality increased by 18%. Again, think about the ultra processed food, even if it's vegan, even if it's like protein bars and even if it has all kind of healthy claims on the package, all of this include in the ultra processed food. Next question would be, what kind of diseases are consequences of consuming ultra processed food? So this is one example. Again, BMJ 2018, ultra processed food risk and consumption and cancer risk, mostly breast cancer. Again, BMJ, they like this topic, 2019, cerebrovascular disease and ultra processed food consumption. And I think this paper is even more important than the rest. And I hope you saw that the high number of participants in each one of these cohorts from Europe, most of them. But here they took it one step further. And when I think about ultra processed food, at the first glance, I reviewed these papers. I thought for myself, okay, what's the breaking news here? You know, we know that ultra-processed food is high in saturated fat. We know that ultra-processed food is low in vegetables. We know that ultra-processed food is high in sugar. So of course it's not healthy. I mean, what's the big deal here? What's the breaking news? But here they stratify to all this. You know, they stratified to saturated fatty acid, to sodium, to sugar intake, to dietary fibers, and even after stratifying to all of this, they found a correlation between ultra-processed food consumption and cerebrovascular disease. So there is something in ultra-processed food which is not healthy, which is probably on top of all what we know about food and all what we know that causes disease, all the food groups that we know that causes disease. And a very important question, which is mostly unsolved these days, is I mean, what's in the ultra-processed food that is not healthy? Few interesting studies on this topic. And again, this is from Cell Metabolism in 2019. And this is like amazing how, you know, the level of the journals that published about ultra-processed food in the past few years. And what they did here is a very, very interesting study. It's from the NIH. So they recruited 20 patients, very, very small group, 20 patients. And they divided the 20 patients to two groups of 10. And group number 1 received for 14 days ultra-processed food. And the group number 2 received for 14 days minimally processed food. But the diet were matched for everything, for the calories, from the sugar, for everything, for the fat, for the fibers, all the macronutrients. The only difference was ultra-processed food versus minimally processed food. Okay, and after 14 days, they switched between the groups. So you had 20 patients that were the control of themselves, that for 14 days consumed minimally processed food, and for 14 days consumed ultra-processed food. And they were able to eat as much as they want, okay, as much as they felt like they want to eat. And this is the outcomes. These are the outcomes. Maybe you can look at them at this curve first, and you can see that during the 14 days on the minimally processed food, or here they called it unprocessed food, they actually lost on average 1 kilo. And again, think about that as a clinician. With eating as much as they want, they lost 1 kilo in 14 days. That's actually more than great. And during the 14 days on the ultra processed food, they gained weight, approximately the same amount, 1 kilo on average. And if you look at the upper graph, you can see that during the ultra processed food time, they consume 500 calories more. So there is a calorie issue here. You know, from here is to your interpretation. You can think that ultra-processed food is more delicious than unprocessed food, and therefore they ate more. Most of the people that work with food will disagree. I think that, and we know, I will not cover this in this talk, but we know that ultra-processed food has all kind of addiction component to it, and if you disseminate food addiction survey to people that ate ultra processed food, you can find all kind of food addiction. So I think that might be one of the potential reasons, but we don't know. We just know that if we give people food to eat as much as they want, so if it's minimally processed food, they will lose weight, and if it's ultra processed food, they will gain weight. Taking this one step further, this is a study from Israel, actually, from Sheba, from next door. Again, a very high prestige journal, the Science Translational Medicine, and it's from Amir Tirosh, the head of the endocrinology division here at Sheba. He worked with Iri Shai, that you probably know. And what they did here in this study, they took the direct study. It's a New England Journal study that was published, I don't know, maybe 5-10 years ago. What this study looked at is the differences between, I think it was low-fat diet, low-carb diet, and the Mediterranean diet. And what they did, they took all the outcomes unrelated to the diet that people consume, and they looked at the level of the propionate in their diet. And propionate is one example of a food preservative. You can find it mostly in all kind of bakeries and pastries and in many packaged food. And what they found that unrelated to BMI and unrelated to body fat and unrelated to everything, they found a correlation between propionate consumption and insulin resistant. And this was an examination of only one ingredient of ultra processed food, and that might be the top of the iceberg and might be not. And when I talk about this study, I think about the trans fat that more than decades ago, people thought they found an amazing fat that is better than the saturated fat, and suddenly it took a few years and we understood that trans fat is not healthy at least as a saturated fat. And food and ultra processed food includes so many ingredients and so many additives that we don't really know their impact, unrelated to the food group. And this is just one example how you can increase your insulin resistance even if you consume low fat or low calorie or whatever, if your food includes propionate. And I hope, or you're probably aware of Michael Pollan's work, and sometimes journalists summarize very beautifully, like in one sentence, what scientists working on for 10 years. And one of his food rules is eat all the junk that you want as long as you cook it yourself. And this is one of the rules which summarize beautifully what we have just discussed. And also, if you look at this from the epidemiology perspective, you can actually see, and this is a nice review that Darius Motsefarian published. He is like the dean of Tufts Nutrition School, one of the most important nutrition scientists these days. And he reviewed what we know about food, not from the culinary medicine perspective, and he categorized food to benefits, harm, and in between. And you can see that if you looked at these foods from the home cooking perspective, so here is most of the stuff that you cook. Here is most of the stuff that is ultra processed. And here are unprocessed food, which is not so healthy. So they are like in between, like the red meat and the egg and the cheese. And moving back to the novel food classification, I'm not trying to say that it's not important if you eat vegetables or beef. Of course, it's important. And I think that if I try to look like 10 or 20 years from now, I think there might be some kind of classification that will combine the novel food classification with the traditional food group that we know. But for now, it's very interesting to look at food from the novel food classification perspective and see even if you eat beef and which is not ultra processed food, what's happened to the outcomes of the papers. So I think that with the science I just presented, it's kind of obvious that more and more people understand that home cooking is important. And if you looked at hospitals, for example, here at Sheba, I don't know to what degree you know Sheba, but we have, I think, 4 gyms within the hospital. And just now this year they launched like an amazing gym for the employees. So literally Sheba invests like millions in helping people to move. And we don't have even one teaching kitchen that train people how to cook. So it's kind of a mystery why we like the management, and Sheba is not unique in this perspective. I worked also in Spaulding, as Ronnie said, in Boston, and in Spaulding as well has like an amazing, just amazing gym on the waterfront, without such thinking about food. And usually the food counseling is RD and a patient that do one-on-one counseling. And if you compare that to the money that invested in training people how to move, to me it doesn't make sense, and to many other people. And you know, most of the clinicians and most of the researchers would say that, you know, understanding food is more complicated than understanding physical activity, and that implementing healthy food regime is more complicated than implementing like physical activity plan. Yet we're not investing a lot with helping patients, and those who believe in culinary medicine just envision what would happen if just next door to the gym we'll have teaching kitchens. And Ronnie, I hope you remember this is from the time that we worked together.
I completely recognize this image. Yeah.
And just imagine what would happen if just next door to the gym we'll have teaching kitchen with RDs and chefs that will teach people and clinicians and patients how to cook the prescription they receive from their RD or from their physician. So this is one of the definitions of culinary medicine. This is really new, so we don't have an agreed definition yet. So the definition on the American College of Preventive Medicine website is a practice of helping patients use nutrition and good cooking habits to restore and maintain health. So let's see if this really can help patients, if this really can help patients to improve nutrition and to improve overall health. So these are like the only, I think they're working on another systematic review. I think it hasn't been published yet. So these are the only systematic review that were published on this area. And it's really interesting because it's the same group that published the two systematic reviews, as you can see from the reference. Actually, it was published in the same journal. And what's interesting is that the first systematic review that evaluated the effectiveness of intervention that includes cooking reviewed the literature from 1980 to 2011. It's more than 30 years, and they found only 28 studies. And the next one evaluated like only 5 years, and they found more studies. So it's really a hot topic that emerging these days. The good news is that it's quite obvious that cooking workshops improve cooking knowledge, cooking skills, improve cooking confidence, improve diet quality, which is quite important. However, it has inconsistent health outcomes, and you know, the authors of these systematic reviews thought that we really need well-designed studies. We don't have good studies yet with long-term outcomes that evaluate home cooking interventions. And actually, there are a few groups these days that are working on this, and one of them is the group is my group. My team is working on this kind of study. So the study that we are working on is we are evaluating the effectiveness of very unique home cooking intervention, which we deliver through telemedicine. You know, this is very interesting and very unique because we started this study before the corona, before the COVID pandemic. So we were like well prepared to the COVID pandemic before. So it almost didn't impact the study, and now we are working on finalizing the outcome. But let's start with the beginning. So the program is a 12 30 minutes televisit through the Zoom, and the televisits include both culinary training and health coaching principles. So in each meeting, we train the participants with culinary tips, with all kind of training that they need. We finish the meeting with few goals to the coming week. And then we meet them after a week. In the following week, we review the goals. We understand what worked for the participant, what didn't work. And we see what are the barriers, what are the facilitators, and how we continue working to improve the home cooking. And what's important is we do not recommend any specific diet. We really meet patients where they are. If they would like to learn to cook more vegetables, they will cook more vegetables. If they would like to learn to cook more meat, they will cook more meat. If they would like to learn how to improve the breakfast, this is what we are working on. If they would like to learn how to improve their dinners, this is what we're working on, and so on and so on. It's a multi-center randomized controlled trial with a 1-year follow-up. We recruited patients in Tel Aviv and in Boston with overweight and obesity, and our primary outcome was 5% weight loss in 6 months. We aimed for 5% weight loss because this is the amount of weight loss that the FDA is looking for when they approve a weight loss medication. So we were kind of ambitious to prove that the home cooking intervention can be as effective as weight loss medication. And we are now analyzing the data, but what I can share with you is a preliminary analysis that we did around a year ago. And back then we have, as you can see, 11 participants that finished 11 participants from the intervention group that arrived to the 6 month point, and 13 patients that arrived to from the control that arrived to the 6 month point. So we have a total of 24 patients back then that completed 6 months of the study. And you can see that even then, the result was significant. So the average weight loss of the intervention group was a little bit over 4%, and the average weight loss of the control was a little bit less than 1%. And back then we had also 14 that finished the study and arrived to the 12-month point. And what we were happy to see that the weight loss were maintained for up to 12 months, and the control even gained more than 1%. So this program might be impactful, and again, we are now working on the analysis, the final results. What you can also see that if you ask yourself, okay, so why people lost weight? So you can see that like the dramatic decrease of the ultra processed food consumption of the intervention group. You can see that the average ultra processed food consumption of the control was 1,500 grams, and the intervention consumed half of the ultra processed food that the control group consumed. And even back then, that we had only 24 participants, it was already significant. I won't go to this area, but there are more and more studies that also present the emotional benefit of home cooking. And I will only present that, as I shared with you, we started this study before the COVID. So we decided that after the COVID came, that to see whether the intervention helped people to cope the stress of the pandemic. So we evaluated only patients that arrived to our to our research team between April and May of 2020, like during the first wave of the pandemic, and we found that self-care and home cooking was a coping strategy, and we also found that people in the intervention group were more resilient to the pandemic than people in the control. but those were only small numbers because we looked only on people that, we didn't ask people to come to take measurements during the pandemic. We only measure people who were scheduled from the beginning to come between April and May to complete questionnaires and to give blood samples. So, to summarize this this section, so I think that if you think, okay, what can I take home? What can I take to my practice? What can I take to my clinic? So, I think that if your patients eat primarily outside or primarily ultra processed food, so empowering patient to cook more at home and empowering patient to cook from scratch could be a good strategy. And if your patients already cook at home, so I think empowering them to improve the ingredients quality or to improve their cooking techniques quality could be a great next step. So let's move to some practical aspects. So let's move to cooking legumes. From our experience, patients have questions and lack of confidence in so many areas of cooking legumes that start with how to purchase legumes. So just so you see, all the tips that I will present here are from a paper that we published quite a while, but it's not something that changed during the time. And it's open access, and you can just go to this link and download the paper. It's although it's a scientific journal, it's a paper about how to consume more legumes, and that's about it. And by the way, if you're interested in culinary medicine and if you're interested in home cooking, so I think maybe it was 2 years ago, 3 years ago, we founded a topic on the American Journal of Lifestyle Medicine. It's a culinary medicine corner, and every volume we were the editors of it's like a colleague of myself and I, we were the editors of a culinary medicine corners, and we published a very short review about the topic and a recipe. So if you collect all these recipes and the recipe that you can find in this study, so you'll have 20, 30 peer review recipes that you can share with patients, and I think that could be a great start if you think about implementing this topic into your practice. And maybe if you talk about implementing this topic, so maybe just another tip before moving on to legumes. So what we recommend our students, and I will share a little bit more later, that we are training clinicians to use more culinary medicine in their practice. We train clinicians to have a library on their desktop with staple recipes that represent important home cooking topics. For example, one recipe about how to cook a fish, one recipe about good salad, one recipe of a legume stew, one recipe of a soup. Like 5-6 recipes that can serve you as a starting point. And you can just send one of them to your patients if they have goal in this area. Anyway. Let's talk about legumes. So I hope you know that you can buy raw legumes or frozen legumes or canned legumes, and I think I would recommend buying in this order. Ideally, it would be raw legumes, but if you prefer to buy frozen, that's also fine, or canned. And if you buy raw legumes, so the shelf life of the legumes is very, very long. I mean, it's like few months easily. You can store it in your cabinet or on your shelf or whatever. And what's many people do not know, that you can actually cook legumes and freeze them very easily, and then defrost legumes whenever you want. And I'm just moving to a very important culinary medicine topic, which we call batch cooking. And batch cooking is cooking big batches whenever you have time to cook. And I don't know if you would like to take 10 seconds and think what will help you to cook more for you. So most of the papers will present that the number one barriers for home cooking is time. And as much as we will help patients to and ourselves to find solutions that will save time, we think that it will be helpful to improve the home cooking, and batch cooking is an amazing tool. And if you cook a salad that asks for 1 cup of legumes, so cook the whole batch and use 1 cup to your salad and freeze what's left in the freezer. And then you have frozen legumes that you can use whenever you want. Many people think when they hear about batch cooking, they think, well, I'm not such organized. I mean, I don't know what I want to cook tomorrow. It's not for me. So the good news is that you do not need to be organized to batch cooking, because if you store 3 cups of legumes in your freezer, you don't necessarily need to know when you're going to use them. And that's the beauty of of batch cooking. They can be stored in your freezer for how long you want. And maybe next week, maybe next month, maybe in 3 months, you'll feel that you will come home late. It's like 6, 7 p.m. and you'll need some first step items to make food for yourself. So you could defrost the legumes and just make a salad out of them, make a hummus paste out of them, or whatever you would like to cook. I'm kind of out of time, so let's move fast. The way to cook legumes is very straightforward. You just cook them with boiling water, a little bit of salt. The cooking times really depend on the size of the legumes, but you just cook them until they are soft enough. And then you can do with the legumes so many great dishes. You can do with the legume soups, and this is an example of a pea soup. I just cooked pea with water with all kind of herbs, as you can see here. And when the pea was soft, I pureed the soup into really nice pea. I think I used here mint, pea and mint soup. So, but you can use any herb that you like. You can use any legume that you like. And Ronnie, I'm happy to share a few of these recipes to the summary that you will
Great.
That you will present after the talk. And this is example of a salad. Again, here I use orange lentils, and I think that orange lentils are a great example how to understand that cooking legumes doesn't necessarily need to take hours and days. So usually when we think about legumes, so we think about soaking the legumes and then cooking the legumes, and it sounds frustrating for some of the people. So the good news is that lentils are not, you don't need to soak lentils. And I think you can see here that I used orange lentils, and the orange lentils are so small that you cook them 3 minutes. I mean, that's all. And for many patients, I think there is, like, I call it the rice test. If the cooking time of a starch is longer than rice, it's like too long. So it's shorter than rice. I mean, it's like 3 minutes, and you have lentil that you can eat. And of course, you can also make warm dishes from lentils, and this is an example of manjadara, but you can do even more sophisticated stuff. But manjadara is just great. If you batch cook and you cook the whole batch and you store legumes in your freezer, so in really short time you can cook so many great stuff. And this is an example of hummus like dip from legumes that I had in my freezer. And this is how I enrich a fish dish with chickpeas that I have in my freezer, and with frozen legumes, you can make so many great dishes in 10 or 15 minutes. So I will finish with a few slides about what we do in addition to the research that we are working on. So we have a culinary medicine program that we call it the Chef Coaching Program. The goal of the program is to disseminate the work that we do. I hope you understood from my description of the intervention that we developed a very unique educational approach that combine culinary training with health coaching principles, and this is like the heart of all the work that we do, with the heart of the interventions that we are delivering. And we are disseminating this approach to clinicians worldwide through Harvard Medical School. And in the past 5 years, as you can see, we train over like 3,000 clinicians from 47 countries. This is the certificate that we grant at the end of the training. It includes 2 components: chef coaching the basics, and which you receive the skills, and chef coaching beyond the basics when you practice what you learn. And you can really implement this in so many options and so many ways. Private clinicians implemented the program in the practice. We are working with rehabilitation hospital, and one example is working with spinal cord injury patients in Canada, and we also implemented this method in many medical education programs, and we are most proud of the fact that the VA implemented the culinary coaching. Here you can find more information about it, and I really want to leave time for questions. So I will stop here.
Thank you, Rani.